Good afternoon, everybody. How are y'all doing? Good. Good. I want to get a sense of who you are, and I'll tell you a little bit about myself. How many of you are here as clinicians? Okay, couple. And how many of you are here because the topic interests you personally or regarding yourself or family? How many of you are here for a different reason? What's that reason?
I have a 16-year-old foster son.
Okay, foster son. And I'm going to repeat what y'all say. I've been given instructions to repeat so the video can pick it up. So foster mom, what else? I saw some hands over here.
Work training.
Work training, okay. What about y'all?
We all work, yeah.
Same? Okay, that's why you're all sitting together. Okay, yes.
I'm applying for foster care, but also I work with teens.
Okay, applying for foster care and working with teens. Okay, well, welcome. My name is Marisa, and I am a clinical social worker. I work at the Trauma and Grief Center at Texas Children's Hospital, and I'm going to tell you a little bit about what we do. So let's go ahead and kind of jump in. These are the things that we're going to go over today, and some of them are going to be, I'm going to move through them a little quicker than others. Some of them tend to be a little more clinical than others, but I'm also a very informal speaker, as formal as this setup is. So if at any point you have questions, you have a story, you want me to slow down and elaborate on something, please feel free to raise your hand and jump in. I'm happy to take questions as we go, and if it's something I plan to address at a later time, I'll let you know that. So the first thing that we're going to do, I'm going to go over what is the Trauma and Grief Center, who we are, what we do at Texas Children's. The meat of the presentation will be in trauma and grief, just learning about how it affects teens and children. I'm going to give you some post-Harvey findings and how, kind of what we've seen mental health-wise in kids following the flood. And then anytime I do a presentation on trauma and grief, especially for those of you professionally and personally who are dealing with that in your lives, I feel like it's my ethical obligation to include information on secondary traumatic stress, vicarious trauma, and self-care, and how you can take care of yourself. I think that those topics are not only important to the work that we do and how this may impact your lives personally, but it's vital, and so we have to include that in our discussions. So with that said, who are we, the Trauma and Grief Center? How many of you have heard of the Trauma and Grief Center? Okay, a few people. So we are a clinic within Texas Children's. We're an outpatient clinic that serves children ages 7 to 17 who have experienced different types of traumas and or losses. We are primarily serving those children who are coping in what we would say a maladaptive way. So who are having additional troubles in their lives, they're needing some extra support. We see kids who have a high level of post-traumatic stress reactions. Maybe they're not coping with their grief in a healthy way and it's impacting their lives. We see kids who are at risk for depression, suicide, things like that. So we see the kids who may have been through traditional counseling and it's just not working, they're not getting better, or needing a higher level of care. And all of our services are free. So within the Trauma and Grief Center, we have kind of three main components of what we do, similar to the Hope and Healing Institute. And we provide our clinical services, which is our clinic. We also do research to look at, are the treatments that we're doing still effective? Are they working? Are there things that need to be tweaked? As well as a lot of grief research and how children understand grief and how they grieve. And we'll talk more about that as we get into the presentation. And then we do education and outreach like I'm doing today. We have some special programs. So my primary role right now is I'm actually supervising our clinicians who are providing services in the Santa Fe, Texas community following the school shooting last May. So we have services out there. We have our Harvey and Resiliency and Recovery program that came about after Harvey and allowed us to do some specialized trauma and grief focus groups within some schools that were heavily impacted by Harvey. And then we currently have one mobile unit that we have a therapist sitting on through Texas Children's, and we're in the process of getting our own mental health focused mobile unit that will go to several different schools in primarily underserved, undocumented areas, and provide clinical services there to children. A lot of them have experienced immigration trauma, separation trauma, things like that. So those are some of our special programs. And I did forget to mention, but our director is Dr. Julie Kaplow, so it's very important. And that's a little bit about us. So, and I will put up some information later as to how we take referrals. All of our referrals are, the family has to call to refer themselves. So we don't take referrals from other professionals unless it's kind of an extenuating circumstance, but we want the families to self-refer. And so I'll give you some information on how to do that. Okay, so let's kind of jump right in. I like to acknowledge at the beginning of any of my talks that, we've all in our lives as adults likely experienced some sort of trauma or some sort of loss. And so not only might we be working with people who've experienced these things personally and professionally, but we might have experienced some of it ourselves. Some of this information may be triggering for you. And so that's, if you need to get up, take a break, walk out, check your cell phone, whatever, that's fine. I don't take offense to it. Just kind of monitor yourself as we move through this. And if you need to take a break, please do so. So how do we define trauma? So there are lots of different definitions of trauma, but the way we primarily define it is when a child feels intensely threatened by an event he or she is involved in or witnesses. So how many of you personally or professionally know of a child in this who's been through a trauma? Okay, the majority of people. So there are two different types of traumas. There are acute traumas, so more kind of one-time traumas. Those are car accidents, natural disasters, terrorist acts, school violence, death of a loved one. Can y'all think of any other acute traumas that you're aware of or that you've experienced or had children that you work with experience? More one-time events. No, the list covers everything. Okay. The other type of trauma are chronic, and these are the more ongoing types of traumas. So these might be domestic violence, witnessing domestic violence, child abuse and neglect, chronic illness of the child and or the parent, living in poverty. Poverty can be a trauma in and of itself. Community violence, witnessing, experiencing it firsthand, having an imprisoned parent, bullying that's going on in the school. How many of you are working with kids who are experiencing chronic traumas or have experienced chronic traumas? Okay. Anything else that's not on this list that you can think of for a chronic trauma? Homelessness, for sure. Okay. So when we talk about trauma and then we talk about post-traumatic stress, I want to be clear in the difference. And so post-traumatic stress is the psychological or behavioral responses that arise in response to trauma, right? And so this is very individual. This is very subjective. Everyone's post-traumatic stress reactions are different. Some are more intense and severe than others. Some are more, have more impact in a child's life than others. We see kids who are super, super resilient and are able to go on with their life and don't experience a lot of post-traumatic stress reactions. And then we see kids, depending on their circumstances, that, it becomes debilitating. And there are a lot of different factors that come into play here that we'll touch on. So when we see traumatic stress in kids, it can look like all of these different things: anxiety, ADHD, depression, conduct problems, and physical illness. How many of you have worked with kids who have been diagnosed with any of these? And how many of those kids do you come to find out have been through a trauma or a loss? A lot of them, right? So a lot of these kids get diagnosed with these different diagnoses, and really it is traumatic stress reactions that kind of look like these other illnesses and diagnoses that we see in kids. And sometimes, and not all the time, but sometimes treating the trauma or the loss appropriately and helping the kids process that in a safe way can actually reduce a lot of these symptoms. Okay, So now I want to move into what is bereavement and grief. And what I forgot to mention about the Trauma and Grief Center is that we are a specialty clinic. We are one of 20 sites through the National Child Traumatic Stress Network that is, we're called a Category 2 site, which means nothing to you. But what that means is that we are one of 20 sites in the country that has a trauma specialty. So there are sites that specialize in human trafficking or, early childhood abuse and things like that. Our trauma specialty is bereavement. So we are especially interested in and tasked with looking at how bereavement and how grief affect children, and how does that manifest, and how does it look over time, and how do children grieve, and what is considered healthy or adaptive grieving versus maladaptive or unhealthy grieving. And so that's kind of what we'll get into now. So a lot of people use the terms bereavement and grief interchangeably, right? How many of you have heard of those used interchangeably? Bereavement, grief, loss, it's all the same. Okay, so I want to be clear for the purposes of this presentation that they are different. So bereavement is the experience of deprivation by loss or death. So it's actually just the loss. That's the bereavement part. That's the bereaved part. Grief is the psychological or behavioral response that arises from bereavement, okay? So grief is to bereavement as PTSD is to trauma, okay? I'll say that one more time. Grief is to bereavement as PTSD is to trauma. So grief and PTSD are the reactions that come from trauma and bereavement, okay? So why is this important? We know that bereavement is the most frequently reported type of adversity in clinic-referred youth. The worldwide lifetime prevalence of kids bereaved by the death of one or both parents was 151 million in 2011. And I think this is a big one. The death of a loved one is identified as the most common and distressing form of trauma among adults and youth in the general population. And so when we talk about helping organizations become trauma-informed, we feel like that might not be enough, that we also need to help organizations and schools in particular become grief or bereavement informed as well, because we don't treat trauma the same way that we treat grief. So we focus heavily on how loss impacts the children in addition to trauma. So there are a lot of studies, and I am not a researcher, full disclosure, I'm a clinician, so I kind of learned a lot from Dr. Kaplow because she is a researcher. But what we do know is that there are a lot of studies that look at childhood bereavement, so the loss of a loved one, and then outcomes. And so what they find is that kids who experience a loss have all of these problems: depression, anxiety, substance use, suicide risk, conduct disorder, and PTSD. What we don't know is what's in between, right? So you have the loss, and then there's something here, and then you have the outcomes. So what is that something? It's grief, okay? So where's the grief? So how do children grieve once they lose a loved one, and how does that influence the outcomes? Because it's not just the loss itself that means that you're gonna end up having all of those psychological problems. There's stuff in the middle that we have to consider. So the grief reactions, and not simply the loss, play an important role. So most kids who experience bereavement do not go on to have psychiatric or psychological issues. And that's important to remember because we don't want to over-treat grief. It can be very normal and normative to grieve in certain ways, and we'll talk about what those ways are. But what's missing in the literature is how children grieve and what factors influence grief. And Dr. Kaplow always says that the field of childhood grief is about 20 years behind childhood trauma. So there's still a lot of work to be done in learning about childhood grief. So how do kids typically grieve? What do we typically see in kids? So that's hard to define. And part of that reason is because there are really few large studies of bereaved kids. There's even fewer studies of kids who are followed over time. There are even fewer studies of culturally sensitive samples, right? So most studies of bereaved kids are done with Caucasian middle class kids, and we know that that is not representative of a lot of children. And what are their grief reactions influenced by? So their age, what stage of development they're in, right? A 5-year-old, a bereavement or a loss is gonna affect them. They're gonna grieve differently than a 16-year-old. Their previous life experiences, the relationship to the deceased, their culture plays a huge role. Religious and spiritual beliefs, so children can often have really strong spiritual connections to the deceased. Their family, social environment, and the cause of death. Okay, so these are the factors that influence how children grieve. And so we're left with a lot of unanswered questions that are attempting to be answered. What does childhood grief look like in children of different ages and in different cultures? What do we mean, and so by healthy or adaptive grief or unhealthy or maladaptive grief? What constitutes a healthy reaction versus unhealthy? How do we know which is which? How does grief change over time? Because we know that it does change over time. When and how should we intervene? So we have parents who call our clinic all the time and say it's been 4 months, my son's dad died and he's just crying every day. And having trouble in school, can't pay attention. I want to bring him in for services. And the reason that we start all of our children who come into our clinic with a very extensive assessment to determine, do they even need our services, or is how they're grieving at that time pretty normal for them and they're doing okay? And a lot of times the parents just need to hear that this is actually pretty normal, the way that your child is grieving and the reactions that we're seeing in your kids. So in an attempt to answer these questions, Dr. Kaplow, my boss, and a lot of her colleagues created what's called multidimensional grief theory. So how many of you have heard of the stages of grief? Okay, so this is a different way of looking at grief. It's a different theory, a different way of looking at grief, especially in children. And so I'm going to get a little clinical, but I want those of you who are not clinicians to stick with me and let me know if you want me to slow down or have any questions. But the theory is that you're not necessarily experiencing good grief or bad grief, right? A lot of the terms that we use, especially with adults, like complicated grief or prolonged grief, things like that, traumatic grief, you either have it or you don't. And that's not how we view grief in children. Like, you either have good grief or you have bad grief. The thought is that you can actually kind of be on this continuum and you can be coping really healthy and adaptively in a certain domain, but you can also have some maladaptive responses in a certain domain. And this theory encompasses 3 different domains, okay? The first domain is separation distress. So that is yearning or longing for the person who died. So it's just the fact that you are separated from this person is causing you distress in your life. And an adaptive or normative way of coping with separation distress is that even though the person has died, the child still feels really connected to them. They still feel their presence and like they're there and supporting them in a loving way. It could be a way of connecting with, if a child loses their mother and the mom liked to bake, then the child may start baking to feel connected to her mom. That's an adaptive way of coping with that distress over the separation or the loss. The existential or identity distress is kind of those questions like, who am I without this person? What is my life meaning without this person? An adaptive way of coping with the existential or identity distress is wanting to help other people who are going through similar situations like what that child went through. Taking on a parent's positive traits in order to help that child kind of succeed throughout their life. So those are some adaptive ways that we would cope with our existential or identity distress after a person dies. And then the circumstance-related distress is what it sounds like. So that is distress over how a person died, distress over the circumstances surrounding the death. And an adaptive way of coping with this is something like Mothers Against Drunk Driving, right? So creating some kind of organization to help prevent others from dying the same way that person died. That would be an adaptive way of coping with circumstance-related distress. And we're going to get into the maladaptive ways in a minute. But are there any questions about this theory and the different domains? Okay. So, and I know this is a little bit hard to see, so I'm going to read it to you, but this is an example of maladaptive way of coping with separation distress. So can anybody tell me what y'all see in this sketch?
3 against 1.
3 against 1, okay.
In terms of, inclusion, exclusion.
Right, in terms of inclusion, exclusion. So they are back here, it's a group of friends saying, hey, why don't you hang with us anymore? And she's here thinking, it's better not to get too close to people. I don't want to feel the pain of losing someone else ever again. Okay? So that would be a maladaptive response to separation distress. She is yearning and longing for the person who died. She's very distressed over that separation. And so her response to that, her way of coping with that distress is to say, I'm just not going to get close to anybody ever again. So that's a maladaptive way of coping, okay? But she could also have really adaptive ways of coping with it. She could also have adaptive ways of feeling connected to the person who died. So for this theory, it's not either or. You're not adaptive or maladaptive. You can have both. This is facing the challenge of existential identity distress. And so she's looking at a picture of her loved one, and she said, I'll never love anyone the way that I loved you. I will never love again. Okay, so this is having an impact on her identity, on her future, who she is as a person, saying, I'm just never going to love again. And then this is the challenge of circumstance-related distress. So this is a picture again of her loved one, and she says, every time I see his picture, I can't help thinking about the night he got killed. It gets me so mad that it's hard to remember the good times. Okay, so she's so preoccupied with the way he died and unable to think about all of the positive things of their relationship because she's just focusing on those negatives and on the way that he died. Okay. One of the reasons that a multidimensional theory and the different domains are really important is because kids can have different maladaptive responses at different ages, right? So in younger kids, we tend to see higher separation distress than in teenagers, where we see more existential and identity distress. Okay, why do you think that is? Why might that be?
I guess developmentally, a teenager would have more of a emotional connection to a person,
Mm-hmm.
or more of an abstract concept of what just happened, while a smaller child would be that person is gone and they're no longer here. So they kind of, it's more of them not being
The physical loss,
Yeah.
right? So she said that the teenager might have more of an abstract connection to that person, more loving connection, not necessarily loving, but whereas the younger child, it's more of the physical loss, the physical separation of that person. Also, something to consider is in different areas you might see different types of distress. So for instance, Dr. Capello did a study in Michigan and found that in Detroit, there are higher levels of circumstance-related distress than in Ann Arbor. Can you think about why that might be? Yeah.
The way that the finances of the city, more job loss and people moving around more than maybe in the other cities.
Okay, so more job loss, people moving around more. What else might be influencing distress over the way that people are dying in Detroit?
Crime rates in Detroit versus what's going on in Detroit versus in Ann Arbor.
Right, so the way that people are dying in Detroit is more traumatic. It's more crime related, more murders, homicides, suicides, things like that. The other thing to think about just for us as clinicians is that we treat different domains differently. So if a child is high in separation distress but not in circumstance-related distress, in our treatment we're really going to focus on helping them find healthy ways to connect with their loved one versus treating some post-traumatic stress symptoms that might come up from the circumstance-related distress, where we might need to help them process the trauma of how they lost that person. So this really impacts finding out where kids are in each domain, high or low, adaptive, maladaptive, really impacts how we treat kids and how we tailor our treatment towards their specific needs, okay? The last thing I'll say about this is that one of the examples we sometimes show in our trainings is of a child who witnessed a car accident, was in the car, they got in a car accident, her mother was killed right in front of her, versus a boy whose mother had cancer and was sick for many years, and he watched her suffer with that illness, and then ultimately she died. And the example shows that for the child who witnessed the car accident, she actually had really, really low levels of post-traumatic stress and really, really high levels of separation distress. And that's the opposite of what we would think would happen. We would think that she would come in and have these higher levels of post-traumatic stress from the circumstances of the death because she watched her mother die in a very traumatic way. But she didn't. And had Dr. Kaplow and her team intervened and treated her as though she had post-traumatic stress, without first seeing that actually all she was doing was really yearning or longing to be with her mother again, they could have done some damage to her. So it's just something to remember as you work with kids or you interact with kids who have been through a loss. We can't assume that just because of the type of loss that they're coping in a maladaptive way to these different domains. Does that make sense, or did I thoroughly confuse everybody? Okay. I see a few head nods. I'm going to hope that means that makes sense and not that I confused you. Okay, so we're going to move in, just for the sake of time, to trauma and loss reminders. How many of you have heard of these terms? Okay, so trauma and loss reminders is kind of a fancy word for triggers. Okay, so we're going to talk about trauma reminders first. So trauma reminders are images, sounds, smells, people, situations, really anything that you experience through any of your 5 senses that remind the child of the event itself, of the actual traumatic event. It takes them back. It flips that switch back in their brain to say, you're in danger, you need to panic, you need to fight, flight, or freeze. Trauma reminders can often lead to post-traumatic stress disorder. So if you think about, for instance, veterans who are coming back from war, what do we think about as things that kind of trigger them in our environment here?
Construction.
Say it again.
Construction.
Construction. What about construction?
Like the loud noises.
Loud noises. Okay.
Law enforcement.
Law enforcement. What else? Gunshots, things like that, right? Flashbacks, nightmares, any of those things can be reminders. So even though they're out of the situation, there are things in their environment that are triggering them on a daily basis. When I work with the kids in Santa Fe, there are things in their environment, both at home and at school, that trigger them on a daily, sometimes hourly basis that they're not even aware of. And the way that one of the ways we help identify the kind of more hidden trauma reminders is to help kids think about those times when you're doing fine and then all of a sudden you snap and you just don't even know why. You know, you're like, I was in a fine mood and then all of a sudden I just lost it. Most likely that is when they were reminded of something, or their brain was reminded of something, and their brain said, trauma, trauma, danger, danger, I'm going to release all of your hormones and all of those stress chemicals and hormones in your body, and I'm going to freak you out, essentially. This could be something that a child was eating at the time of a traumatic event. Okay, so maybe that's a food that anytime they see it or smell it or taste it, it takes them back to that moment, right? We all have things in our memories that remind us of things from our childhood, but trauma reminders in particular can be really, really distressing. So part of our work is to help kids identify what are their trauma reminders, what is triggering them throughout the day, and then helping them figure out ways to cope with those reminders. Some reminders can be avoided. So social media, for instance, if for the kids in Santa Fe, seeing things on the news or on social media about other events or even about their event can be really triggering. That's something they could, in theory, avoid, right? Some trauma reminders you can't avoid. You can't avoid a loud noise that sounds like a gunshot, at all times. You can avoid some situations where you know it's going to happen, but we don't always know when a loud noise is going to happen. So helping them identify those reminders and then figure out ways to cope. Loss reminders are images, sounds, smells, people, and situations that remind the child that the person is gone. So being around their friends, their clothing. So loss reminders can often be distressing, but they can also be comforting. And sometimes they start out distressing and then they can turn comforting. I always use my own personal example that my mother died on Valentine's Day. And for a very long time, for many years, I could not look at anything related to Valentine's Day. I didn't even like going to the grocery store anytime within a few weeks before Valentine's Day because it just physically gave me reactions to it. But now it's been many years and I have my own kids, and now Valentine's Day has turned into something that we celebrate with my kids. We honor my mom on that day because she loved it. We talk about her and we celebrate her. So that's an example of a loss reminder that was distressing for a while and then turned comforting over time. Okay? Trauma reminders, always bad. They're just always going to make you feel horrible. Loss reminders can be comforting. So I'm going to give you an example of a case interaction with a clinician and a client, and I do want to just let you know that it can be upsetting to hear these details, so if you need to step out, you can, but I want to illustrate, it really illustrates how powerful these trauma and loss reminders can be. So this was a 17-year-old girl who witnessed the murder of her mother by her father. And the clinician says, do you get very afraid, upset, or sad when something reminds you of what happened? The patient says, oh yeah, screaming, door slamming, firecrackers, that and seeing or hearing arguments. Whenever I hear somebody fussing or anyone arguing, especially if it's a man, I want to run and just go get a knife. It brings me right back. I get to the point where I'm so scared, I'll kill you if you make another move. I wouldn't mean to do it, it's just out of fear. They could even just be playing, but just hearing that scream, it just makes me feel like I'm back there again. The clinician says, and then when these things happen, how much do they bother you? The patient says, on a scale of 1 to 10, I'd have to say 20. The clinician says, have you tried to stay away from people, places, or things that remind you of what happened? The patient says, I can't go to the mall anymore. I went only one time after she died, but I couldn't go after that. There's a lot of stores and stuff that I like there and I want to go so bad, but I can't because I don't have a mama anymore. The clinician says, is that because the mall reminds you of what happened? And she says, the mall just reminds me of her in general. Through good times and bad times, we always went there together. So what would you say are some of her trauma reminders? Door slamming, firecrackers. Arguments, screaming, men's voices. Okay. And then what about loss reminders? Is the mall a loss or a trauma reminder? It's a loss reminder because it reminds her of the loss of her mom, not how her mom died, right? Okay. Are there any questions about loss and trauma reminders? Okay, so, and I'm going to kind of breeze through this just for the sake of time, but when we talk about becoming trauma and grief informed, we just want to make sure that the organization, the school, the family, whoever it is, are screening and asking questions about trauma and bereavement exposure, have resources for the exposure, its impact, and referral recommendations. And then really an environment of care for staff that addresses and treats secondary traumatic stress and enhances well-being. There's one big question you can ask that can help you be trauma informed, and that is, what happened to you versus what's wrong with you? Okay, so a lot of times the kids who are labeled as bad kids, troubled kids, a large percentage, the majority of children in juvenile justice settings have experienced the loss of a loved one. And so these are kids that are often seen as troublesome. They have risk-taking behavior, they act out, and a lot of times it's what happened to you, not what's wrong with you. We don't want to jump to a diagnosis and say just what's wrong with you. Most of the time, more often than not, they've experienced some sort of trauma and or loss in their lives that has not been treated. So real quickly, post-Harvey, what do we see? So how do kids typically react? So most kids who are traumatized or experience kind of post-traumatic stress symptoms following a hurricane have experienced prior traumas and losses. And the most common type of trauma in this sample after Katrina was a death or serious injury of a loved one. The hurricanes and floods in and of themselves are unlikely to result in post-traumatic stress disorder as a diagnosis. That doesn't mean that kids don't experience some post-traumatic stress symptoms or reactions, but the flood itself is unlikely to cause PTSD. There's usually some type of underlying anxiety or trauma or loss that the child already has. And I'm not going to read all of these, but just to talk about which youth are most at risk for experiencing problems following a flood or hurricane, this would be it. And I'll leave it up there for a minute. And then we do want to mention that for a lot of, especially in the Houston area, undocumented families, they can be impacted that much more because they could be really scared to get help, right? For fear that if they ask for help, there are a lot of families who were impacted by Harvey that are undocumented that were not able to access any kind of resources out of fear. And so we want to be able to meet the needs of those families. And there are a lot of organizations and programs that have been doing that and trying to do that. But part of the problem is just being able to get the word out and the trust factor for people to really trust that they can utilize these resources and services without fear of deportation or anything like that. Okay. I want to move into, because I think it's very important. Are there any questions about this before we move into the cost of caring? Yeah.
On the slide before this one,
Uh-huh.
it listed injured themselves or loved one.
Yes.
What kind of injuries, like, not like a broken bone or?
That's a good question. So the question was, it mentions that being injured is puts them at risk. I don't know exactly what kind of injuries. I would assume just being injured in the flood in any sort of way could have an impact on them, could make them more traumatized and have stronger reactions. But that's a good question. Any other questions about the Harvey stuff? Okay, so taking care of yourself. And I hate that this is always at the end and it's the most rushed portion of the presentation, but there are, especially for those of you who are clinicians, you've probably heard of some of these terms. How many of you have heard of secondary traumatic stress? Okay. What about vicarious traumatization, compassion fatigue, and burnout? Okay. A lot of times these terms are used interchangeably, but they actually do have some subtle differences to them. So secondary traumatic stress, these are your actual post-traumatic stress reactions that you experience as a result of the work that you do. It's consequent behaviors and emotions resulting from knowing about a traumatized event, the stress from helping or wanting to help a traumatized or stressed person. Whereas vicarious traumatization is from the work that you're doing, whether it's as a foster mom or as a clinician, but how it kind of causes a shift in your worldview from hearing stories and knowing about trauma and loss. So this is the thought that, everyone in the world is horrible, we're all doomed. I'm using like pretty extreme statements, but you get the idea. So it just causes a shift in how you view the world. Compassion fatigue is gradual lessening of compassion over time. It's just fatigue. It's that I am exhausted from caring for everyone around me and constantly having to show compassion. And then burnout, and I think this is the biggest difference. So these three terms at the top are more in relation to the kind of work that we do in whatever capacity that might be, whereas burnout is actually a reaction to your work environment, so more the demands of your job, okay? Having a boss who isn't helpful or supportive, or having to see 10 clients a day, or having 7 foster kids in your home, things like that. So it's the result of the demands of your job versus the actual work that you're doing. So I think that's an important distinction. And how do you know if you're experiencing secondary traumatic stress? These are small, but depression and hopelessness, feeling overwhelmed, intrusive thoughts and images, pessimistic or cynical, being irritable, feeling aggressive, detachment, numbing yourself, withdrawing, avoiding things, being hypervigilant, so always being on guard, and then having physical symptoms that don't have a medical explanation behind them, constant headaches, constant, aches and pains, stomach aches, things like that. These are all signs not only of secondary traumatic stress, but what else are they signs of? Post-traumatic stress disorder, right? So it's looking for it in yourself, but it's secondary. So you may not have experienced your own trauma acutely, but you're listening to stories of other people's traumas, and so you start to take on and experience some of these symptoms. So that's all the bad news, but the good news is that there is also something called compassion satisfaction. And that is deriving pleasure from helping others, which I think is why a lot of us do what we do, because there is a component of that. And practicing routine self-care is what kind of combats or decreases your risks for secondary traumatic stress, vicarious trauma, and compassion fatigue. And we always talk about self-care in terms of like exercising and eating healthy and getting 8 hours of sleep, and that's not realistic for a lot of people. And I like to view self-care in smaller ways, so ways that you can incorporate it throughout your day, whether at your home or at your place of employment, if you work outside of your home. For instance, taking water with you to work every day so that you drink enough water. For me, I've worked in a hospital for a very long time. I don't see out a window a lot of days, so for me, part of my daily self-care that takes 2 seconds is to take a route to a restroom that includes looking out a window. Okay, so there are a lot of ways that you can incorporate self-care in really small ways. One of the most, I think, helpful ways that we've been able to do this in our work professionally in our clinic is every Monday, and this is something you can do in your place of work as well as with your families at home. I have families who do this at the dinner table every night, and we do gratitude. So every Monday we have a staff meeting, we talk about really difficult cases and things like that, and it was becoming really like just draining and upsetting to like walk out of these meetings and everyone's just kind of feeling heavy. And so now what we do is we go around the room at the end of every one of our Monday meetings and we do gratitude, and we say one thing that we're grateful for that week. And it does a couple things. It helps just shift the energy in the room so that then you're kind of left thinking with, the more positive things. It also lets us get to know each other on a different level than we would if we were just having a normal staff meeting, because people share what they're grateful for about their weekend and their families and things like that. I do this in my counseling sessions with my kids. We end with gratitude and the things we're grateful for, and I suggest that a lot of, like I said, my families do this around the dinner table. I think gratitude is something really important and really simple to incorporate no matter where you are, so it's just something to think about. Does anybody, we only have a few minutes left, so I want to be mindful of time, but does anybody have really good ways that you've found to incorporate self-care into your daily routine?
Well, it's something really simple, but also really aggravating to set reminders on your phone, or like Fitbit will tell me when it's 10 to the hour and how many steps I need, and also have breathing reminders. I'm a pastor, so still in a helping profession,
Right.
As well, absorb a lot of people's anxieties and fears and stuff, and so to have those reminders to just like, okay, get up and walk.
Right, so having reminders on your watch or on your phone or whatever it is to get up and walk, to breathe. I actually shut that off. It was irritating me. I don't want to remember to breathe. Leave me alone. But I think that's a really good idea, just to be reminded on an hourly or even once a day basis to take a breath, to get up and walk around, to be mindful of where you are and why you're doing what you're doing. That's a really good one. What else do y'all use?
There's also some apps.
Yes.
Meditation.
Yes, so there are some apps.
That let you choose like how long.
Right.
So my therapist recommended at the beginning, anyways, a 30-minute thing, and I was like, I cannot do 30 minutes, but now I love it.
There are a lot of apps. We use Headspace a lot for our kids. Also Calm. There are some, you can just do like a 3-minute mindfulness. A lot of times those help with getting to sleep as well. Thank you. Anything else? Yeah.
Commuting in silence.
Commuting in silence. Can you talk more about that?
I might go into the meditation arena, but also just clearing
Okay, so using your commute as a way to be intentional about your thoughts and what you're thinking about and kind of get into your own head. That's great. Some people do the opposite on their drive home. They listen to, different books or podcasts or different music that helps lift them up. But I think using your commute in whatever way you need to, because it's Houston, we all have commutes no matter whether you live a mile from your work or 20 miles. But using that time in the car to really gather your thoughts, zone out, whatever it is that you need at that time, I think is really a good one. Yes?
I talk a lot.
It's okay.
I think another thing that helps me is, like we're in the middle of this big rebranding project at church, so there's like stuff that we're doing, envisioning and working for the future, but also ministry doesn't stop on a day-to-day. So I try to, on Monday, look at what my schedule looks like and actually schedule appointments with myself. So that any white space that's there, then, okay, I'm gonna go to the gym, or I'm just gonna go.
So scheduling self-care into your week, every week, scheduling time with yourself. That's a great one. Okay, thank you for that. Okay, so I'm gonna close up so we have a little bit of time for questions, but these are some really good resources for you. The National Child Traumatic Stress Network, if you've never heard of this or seen this, this is an amazing resource. They have a database of resources, thousands of resources online that address all different types of traumas. There's information for medical care providers, foster care, all different types of resources that you can download and print. They have webinars. It's an amazing, I really can't say enough about it. And then our Trauma and Grief Center, this is how families can make referrals. We do have a waiting list to get in to be assessed by our clinicians, but once you're assessed, if you're recommended for treatment, then there's no wait time to start treatment after the assessment. And then Bo's Place, I hope that a lot of you are familiar with Bo's Place. It's a great resource here in Houston that provides grief support, group support to children who have lost a loved one. And they also have support for the surviving caregiver as well. And then the Shared Grief Project, for those of you who work with teens who have lost a loved one, this is a website where different famous athletes who have also gone through loss as a child come and tell their stories. And so it can be really inspiring and helpful for kids to see, hey, this famous basketball player went through the same thing I went through and look how their life turned out. So it can be very inspiring and motivating, and also just helpful for kids to see that they're not alone. So that's another great resource. And I will put up, this is me, I'm Marisa, and then Dr. Kaplow is the director if you need to contact either of us. And that is all for me. We have about, I think, 7-8 minutes for questions if anybody has any questions.
So, would bereavement be strictly death related, or if a child or family was separated from a parent because of CPS issues for a long period of time, could they also have the same bereavement symptoms?
That's a really good question. So in terms of what we look at bereavement as the death of a loved one, but children certainly have other, we call them more ambiguous losses. So the loss of a caregiver to incarceration, CPS, things like that. Also, kids who lose a limb for a medical reason, or, just experience, after Harvey, losing their home. I mean, there's lots of different ways kids can experience loss. And so I think a lot of what we talked about is applicable to that. In our center, and what we study is specifically bereavement from a death. But that's a great question. And I forgot to repeat the question for the video, but okay. Go ahead.
So my husband has cancer and is not doing well. Are there things that you can do when you know that the loss of a loved one is coming to help the children?
Yes. Yes, and actually in my previous life I worked at MD Anderson with children whose parents had cancer, so we can also talk for a minute after. But the question was, when a parent has cancer, are there things you can do to kind of help and prepare and things like that? And the most succinct and best thing I can say is that it's recommended that you use honest age-appropriate communication. So, and depending on where your husband's getting treated, but there are social workers and child life specialists to be able to help with knowing how to do that. But what we find is that kids who are included in communication and kind of kept open communication fare better than kids where there are secrets. And you know, as parents, we like kind of instinctively want to protect our kids from hurtful information. Like, why do I want to tell them that their dad isn't doing well when that's just going to upset them? But ultimately, the outcome is better when they're informed and kind of kept in the loop along the way. But we can certainly talk, because I have some other resources for you as well. Any other questions? Yes?
The slide that talked about the questions that you asked, what's wrong with you versus what happened to you?
Mm-hmm.
Are there any other common questions that people ask that aren't really helpful, or that can be altered on how you ask it?
That's a good question. So the question was, when we talked about what happened to you versus what's wrong with you, are there any other questions that can be asked or get asked that shouldn't be asked? I think there are many answers to that question. I think one of the things we hear from kids a lot is being asked to tell their story, to tell what happened, and that can often be re-traumatizing if they're not at a place that they're ready to tell their story. So I think what we say all the time and what we practice in our clinic is starting where they are. So even in our assessments, and like I'll use Santa Fe for example, you know, we assess kids in Santa Fe to determine if they're appropriate for our treatment. There are kids who I've been treating for months and I still haven't heard their story from that day. Because they're not ready and we haven't gotten to a place where they need to tell me that. And so I think that's key, is just knowing part of being trauma informed and grief informed is to know that when you're asking kids to go over the details of a trauma or a loss, that can be harmful if they're not in a place where they're ready for that yet. We usually just say, you know, you can tell me as much or as little as you want, but you know, tell me why you're here. Tell me what you hope to get out of being here, but not necessarily, well, what happened to you that you want to talk about? Does that help? Okay. Any other questions? Well, thank you all very much. Thank you for your participation today, and I hope you'll have a good rest of your day.